morning everyone. Today we are going to discuss about the transcatheter aortic valve implantation and its anesthetic concern. We will mainly focus on the anesthetic concern in this lecture. So first we briefly know about what is Tavi and in which cases it should be done. So Tavi full form it means you can say transcatheter aortic valve implantation means we are going to implant the aortic valve, not the surgically removing the aortic valve, by just implanting the aortic valve on the native valve. It is via transcatheter. So it is done in the case of severe aortic stenosis. Now we discuss briefly about the aortic stenosis. What are the causes, physiology, symptom severity, and the management of the aortic stenosis? In the brief point we have to discuss. So first is cause. Depending upon the patient age, we can differentiate. Just like if there is infant and children, the congenital AS also valvular aortic stenosis is very common. But in the young and middle ages, rheumatic heart disease and the calcification and fibrosis of the congenital bicuspid aortic valve is there. And the middle and old age group, senile degeneration, rheumatic heart disease, calcification of the bicuspid aortic valve will causes. And then the physiology about the aortic stenosis is very important because in aortic valve calcification, or you can say stenosis by any cause because of bicuspid unicuspid valve calcification, or rheumatic heart disease causes the calcification of the aortic valve. When the calcification is started, the aortic valve area will decrease and LV will adapt by increasing the force of the LV systole. But till the aortic valve area is not decreased by the half, the gradient will not develop in the aortic valve across the aortic valve. So first gradient will rise when the aortic valve area is more than 50%, and LV will adopt by increasing the force of contraction. First, in early changes what happens actually, concentric hypertrophy will occur, means the myocardial fiber will attach parallelly to increase the force of contraction of the LV to maintain the cardiac output, or you can say stroke volume. This increase in the myocardial fiber inside the left ventricle causes increase in the left ventricular and diastolic pressures. Now this increase in the LV EDP causes the decreased compliance, or you can say later leads diastolic dysfunction. Now this increase and LV EDP causes the atria to push the blood against the high LV EDP, means atria will needs more power to push the blood into the LV, or you can say we know atrial kick only comprises of 15 to 30% of, you can say, filling of the LV. Mostly filling of the LV occur via the venous filling passively. But in these cases, type 1 aortic stenosis, with increased LV EDP, now the atrial kick is more important. It will fill up 70 to 80% cardiac output is, or you can say filling of the LV is done by the atrial kick. So atrial kick is very important. If it lost, then sometimes patient may become unstable, or you can say this instability leads to the heart failure. Over a period of time, the concentric hypertrophy will occur. You can say if the concentric hypertrophy will occur, myocardial ischemia, myocardial fibrosis, decreased contractility, or you can say decrease in stroke volume. Over a period of time, the dilation of the mitral left ventricular, or you can say annulus of the mitral valve leads the mitral regurgitation. One thing I would like to know, I would like to tell over here, if the LV contractility is impaired, or if there is a progressively increase in the obstruction of the aortic valve, or you can say it is beyond the compensation of the hypertrophy of the LV, is exhausted, or you can say compensation is exhausted, the end systolic volume will rises, and additional compensation, just like you can say dilation with the augmented fiber stretch, or you can say Frank Starling mechanism attempt to maintain the cardiac output. And when this preload reserve is exhausted, there is no further compensation is available, and the pump failure will result. Atrial kick is very important because you can see the prominent fourth heart sound in this case also in the examination. If the left ventricular mass will increases, the myocardial oxygen consumption will increase. Over a period of time, this systolic hypertension further raises the myocardial oxygen need, at the same time impedes the systolic coronary perfusion. Prolongation of systole rises further myocardial oxygen demand or consumption. At the same time, it limits the duration of the diastole also. So filling of the, you can say, coronary filling will also decrease. So over a period of time, there is a supply-demand mismatch in this LV. This further leads the imbalance between the myocardial oxygen demand and supply. Acute imbalance may manifest as an internal attack. You can say proximal arrhythmia may occur, or you can say syncope will be there. Sometimes sudden death will occur. This prolonged imbalance then leads to patchy myocardial fibrosis with exacerbation of the impairment of the diastolic and systolic performance. Now this is a complete about the aortic physiology. First concentric and later eccentric hypertrophy and dilation of the LV and pump failure results. Now we will discuss about the progression of the aortic stenosis. In this diagram we will see first symptom are the just dyspnea and the syncope ultimately leads to heart failure, and the severity is defined on the basis of the echo. And we know annually there is a decrease in the aortic wall area by 0.12 centimeter square per year, and increase in aortic jet velocity is 0.32 meter per second per year, and increase in the mean gradient is approximate 5 mmHg per year. So in this clinical stages of the aortic valvular stenosis, and we will see the stage A means the patient at the risk of aortic stenosis have no symptom. There is no hemodynamic consequence and there is no symptom in this. And if we see about the progression of the aortic stenosis, here symptom is also not there. And next is asymptomatic severe AS. These are the in which aortic stenosis is severe. Gradient is more than 40 mmHg, wall area is less than 0.6 centimeter square per meter square, and but still there is a symptom or none, but exercise can show the symptom status. But here the LV ejection fraction is still preserved. And in last stage D, there is a symptomatic severe AS, and in which the first there is a high gradient AS and later is a low flow low gradient AS with reduced ejection fraction, and lastly low gradient AS with the normal ejection fraction or paradoxical low flow severe AS. So stage 2 and D and 1, these are the stages where we go for the surgery or the Tavi, depending upon the patient condition. So these stages is important for us for the aortic wall replacement, or you can say Tavi. Medical management actually in this aortic stenosis is very little to offer. So medical therapies may be necessary for the patient considered to be inoperable because of the comorbid condition that preclude the surgery. That is why there is a recommendation of the in medical therapy. It is a class 1 recommendation for the stage A and B and C. Stage A, B and C, there is no symptom in the stage A, B and C. So hypertension is there, it should be treated. Similarly, there is a class 1 indication in calcific AS. Statin therapy is indicated for the primary and secondary prevention of the atherosclerosis. And in class 2B indication, if the patient undergone for the Tavi is done, then you can start the ACE inhibitor or the ARB. It will further leads to LV remodeling and helps the improve the symptom of the patient. And there is no benefit in the patient with calcific AS to in stage B and C. Such therapy are indicated for prevention of the hemodynamic progression of the aortic stenosis. So you can say aortic stenosis, there is no use of medical therapy if the patient is symptomatic. Once the patient becomes symptomatic, there is a standard, you have to go for the surgery or the Tavi depending upon the patient condition. Now, you can use the diuretic if the patient is in the heart failure, there is abnormal accumulation of the fluid, but it should be used in very caution, because hypovolemia will, we know, decrease the LVDP, but further decrease the cardiac output and they produce the orthostatic hypotension also. And AS inhibitor is also contraindicated, you can't use, but if it is a few epidemiological studies shown that it improves the outcome in the patient with severe AS, but it should be started at a very low doses and avoiding the hypotension. Now the beta adrenergic blocking drugs are the contraindicated in this patient also, and they should be avoided. If we want to decrease the heart rate in Tavi, then we can use the short-acting beta blocker like esmolol. Otherwise, it should be avoided. And the atrial kick is very important in this patient. So if AF will occur or atrial kick will lose, the BP will further decrease. So AF with fast VR should be treated very early, or you can say if patient is unstable, you have cardiovert the patient. Now surgery is actually the gold standard in this patient with symptomatic severe AS. If the symptom is present in the patient, you have to go with the surgery. But there is a European heart survey, approximately shows that there is a 31% people didn't go for the surgery because of the comorbid condition like severe LV dysfunction or the older ages. Then what happened in the 31% patient will definitely die. So we to address these patients, there is a you can say boom in the aortic valve surgery will occur from 2002, where the first Tavi will done by the cardiologist. So you can say for 31% the Tavi can be indicated, but depending upon the all scenarios, if surgeon team and anesthetists, everyone is available and the Tavi facility is available, then you can go for the Tavi in that hospital. So we discuss about the few lines about the Tavi. So in first BAV is done in the 1983, but you can say balloon aortic valvotomy, in which we open the aortic stenosis via the balloon dilation, but there is a high risk of restenosis in BAV. In 2002, the first percute aortic valve implantation occur, and after that the Tavi will evolve, and in 2011 there is a review in which they shows all the patients are categorized high risk according to the STS promise score. So high risk patient are selected, and some patients going for the Tavi and some patients going for the surgical aortic valve replacement. And the data shows in Tavi there is a 7.4% mortality, and in the surgical aortic valve replacement there is a 6.4% mortality. Means the high risk patient going for the saver, there is a high mortality as compared to Tavi. That is why Tavi is indicated in the high risk patient in what the data shows. So Tavi can be done by the different approaches, like you can go with the transfemoral, transapical, transaortic or transaxillary or the transsubclavian. The Tavi wall are the different types, not just like a surgical wall. These are just like a expandable wall by a balloon expandable. You can say these are the self-expandable wall, balloon expandable or self-expandable. These crumpled in the aortic catheter, and then we at the aortic wall site, as we show the figure, and when it reaches the aortic wall site, we measure all the distances in the aortic annulus, LVOT diameter, aortic wall diameter, and the coronaries from where it was arises, all should be measured in the cath, and then we implant this aortic wall, and self-inflatable, it will inflate automatically when we remove the catheter, or you can say balloon expandable, we will just expand via the balloon. But important role here the anesthetist will come, so we will discuss. So first we know the Tavi is indicated in the 7.4% mortality in the high risk patient, so it is very important. But in this Tavi can occur in Tavi can be done in the 4 stages. So transfemoral, transapical, transaortic and transaxillary, in all these the transfemoral approach is very good, or you can say data shows there is a very less mortality in the patient undergone for the Tavi with transfemoral approach. Transapical and these all are the chance of bleeding, or you can say arrhythmia is all there because we are cutting the apex. the arrhythmia can occur if we are creating a site for the arrhythmia. So transfemoral approach is good as compared to other approaches. So there you can say in 2002 we start the Tavi, but see the STS score, we take the only high risk patient. The partner 1B and 1A trial shows very high risk patient. These are the extreme surgical high risk patient, and this is the intermediate surgical high risk, and green shows the low surgical risk. Like patient can go for the surgery, but Tavi is indicated in that patient. So it is, but who will decide that Tavi will occur this patient in the low risk surgery? It is a her team and of the institute, and it can decide if this patient is go for the Tavi or the surgical aortic wall replacement. So from 2002 to 2019, or you can say 20, the risk is you can say we are just decreasing this. You can say we are taking the low risk surgical patient for the Tavi, and the results are very good. In this and in 2020 there is some indication for the Tavi will shows. So indication of the Tavi is only indicated as a class 1C indication. Tavi is should only be undertaken by the multidisciplinary HERT team. So HERT team should be present in that institute. You can say it comprises of cardiologist, cardiac anesthetist, and the cardiac surgeon. They who will decide if patient is go for the Tavi. And Tavi should only done in the hospital where the cardiac surgery is on site. It is a class 1 level C indication. Tavi is not suitable. Tavi is indicated in the patient with severe AS who are not suitable for the surgical aortic wall replacement as assessed by the HER team. So HER team will assess patient is go for the saver, or that patient go for the Tavi. So it is assessment by the HER team, in which the life expectancy is more than 1 year. Or you can say Tavi should be considered in the high risk patient with severe symptomatic AS who may still be suitable for surgery, but in whom Tavi is favored by the HER team based on the patient individual risk profile and anatomic suitability. It is class 2B indicated, but class 3 it is also HER team will decide patient is go for the Tavi or not. There is a several recommendation on the surgical aortic wall replacement or the Tavi. So it is class 1A indication in symptomatic patient, for symptomatic patient and asymptomatic patient with severe AS for any indication of the aortic wall replacement who are less than 65 years of the age, and life expectancy is more than 20 years. Severe or you can say surgical aortic wall replacement is recommended, and it is class A in class A recommendation. Similarly, class A indication is in patient with symptomatic AS with severe AS. Age is 65 to 80 years. Tavi, either surgical aortic wall replacement or the transfemoral Tavi is recommended after shared decision making about the balance between the expected patient longevity and the wall durability. Similarly, for class 1A indication also for those patients who are symptomatic with severe AS with the age is more than 80 years with the life expectancy is less than 10 years, then transfemoral Tavi is recommended in preference with the surgical aortic wall replacement. Class 1A indication is also there if the symptomatic patient with the severe AS and ejection fraction is less than 50% and whose age is less than 80%, then Tavi or saver should we follow the same recommendation as follows the symptomatic patient in recommendation as 1 to 3 above. And class 1 recommendation is also for the asymptomatic patient. Here the patient is asymptomatic with severe AS and abnormal exercise test. Very severe AS, rapid progression with elevated BNP, saver is recommended in preference with the Tavi. Now the vascular anatomy, if the patient was indicated for the AVR for whom the biophysitic wall is preferred, but wall or vascular anatomy or other factors are not suitable for the transfemoral Tavi, then the surgical aortic wall is recommended. And this is the class 1 also. Class 1 also for patient, symptomatic patient of any age with severe AS and a high risk of surgical risk, Tavi is recommended if predicted post Tavi survival is more than 12 months with acceptable quality of life. And lastly, there is a class 1 indication for symptomatic patient with severe AS for whom predicted post Tavi or post saver survival is less than 12 months or for whom minimal improvement is quality in life is expected. The palliative care is recommended after a shared decision making, including the decision of the patient preference and the values. Now there is some contraindication for the aortic valve for Tavi. You can say if the valve is the bicuspid or the unicuspid, or the mechanical valve is already there, we can't go for the Tavi. If the recent myocardial infarction is there less than 1 month, or there is a severe MR, severe pulmonary hypertension, mixed aortic valve diseases, and no cardiac disable accident within 6 months, and there is end-stage renal failure is there, then we severe respiratory distress and life expectancy is less than 12 months. Due to the non-cardiac comorbidities, we do not go for the Tavi. There is some contraindication. Now, in valvular heart disease, there in aortic stenosis, there is some goal. In goal, like we only discussed about the aortic stenosis, the preload should be high because of increase LVDP. We should increase the preload. SVR should be increased, and heart rate should be you can say normal or decrease, and conductivity is normal in the aortic stenosis. So our goal in here are in Tavi or in the Tavi procedure is these 4 goals. Heart rate, we have to maintain the heart rate, preload, afterload, and the contractility. So discuss about the heart rate in which we have to maintain to normal to slow sinus rhythm, so that ejection of the LV will be adequate to maintain the cardiac output. If there is a rate is lower, very low, then we go with the atrioventricular sequential pacing, and if the rate is very high, then we give the anesthesia to the patient, give them water anesthesia or some sedation. If the to maintain the preload, because of increased LVEDP, we have keep the preload in normal to higher range. We give the intravenous fluid, but we avoid NTG, thiopentol or SNP in this patient. To decrease the afterload, to maintain the afterload, in afterload we have goal is high. We have to maintain the high afterload. So to increase the to maintain the high afterload, we give the alpha blocker drug, or you can say you can give the phenylephrine and NORAD to increase the SVR, or to maintain the systemic perfusion pressure, because LV cardiac output is fixed in aortic stenosis. The perfusion will hamper of the other tissue. To maintain that perfusion in the tissue, we have to increase the SVR to maintain the perfusion pressure of the other organ. Now the contractility is normal to increase. If there is a decrease in the contractility, we have to start the vitamin, dopamine or the epinephrine. But in AS, because of the hypertrophy or adaptation, there is a contractility is always normal. But if it is decreased, then we have to go with these drugs, beta 1 agonist drugs, and there is a higher dose beta adrenergic blockers are avoided. Now, what is the anesthetist goal in the Tavi? So first we know if the patient goes into the general anesthesia, then the immobility of the patient is very important. Either we are going with general anesthesia or the local anesthesia with the conscious sedation. Immobility of the patient is very important in the Tavi during the volume implantation, or you can say balloon dilation of the Tavi valve. Hemodynamic stability we have to watch, we have to see, we have to attach every monitor in which we chase our hemodynamic goals in the aortic stenosis and maintain the hemodynamic stability. Control of rhythm is very important to maintain the sinus rhythm, maintain the atrial kick, so that cardiac output will remain in normal size. And if there is a change in the rhythm, we can go with the cardio conversion DC shock at the time of the Tavi also. There is optimal neurological monitoring should be there, because we are handling the aorta, and if the aorta is calcific, or you can say there is a mild thrombus maybe in the aortic root or sending aorta, it may goes into the cerebral artery, which causes there is some neurological deficit may occur. Check the prosthesis implantation with the transesophageal echo. In the general anesthesia, we can put the transesophageal echo and see the complication caused by the aortic valve implantation or Tavi, just like a paravalvular leak from the Tavi valve. If the calcium is very thick and the valve, after valve implantation, that calcium sometimes is not displaced, or you can say is it creates some gap between the wall and the native aortic root, and that causes the paravalvular leak. Management of the airway and the mechanical ventilation is our goal, and control of breathing and prevention of positive complication is mostly by the surgeon and the cardiologist, but these are our goal. We have to manage these goals during the TAVI. So first, to maintain the difficult airways there, so difficult difficult airway trolley, all the equipments are available. For hemodynamic instability, we have to do the TAVI in the OT, which is hybrid OT. What is hybrid OT? Means patient going for the TAVI, so NGO is available, surgeon is available, perfusionist is available, bypass machine is available, cardiac anesthetist is available. Everyone should be available on site when the procedure TAVI is going on. In the patient, the peer evaluation should be done peer evaluation is very important in this patient, and all systemic examinations should be done. Rule out any other comorbidities, and CT scan, multi-slide CT scan, echo, and all measurements is required in the TAVI. There is a fixed protocols for the TAVI in which we have to see all the measurements requirement in the TAVI. For the monitoring intraoperatively during the TAVI, we have to attach ECG, we have to monitor the arterial pressure, we have to monitor the pulse oximetry, capnography, temperature, urine output via UCAT, and defib pad should be attached. Additional neuro monitoring we have to done intraoperatively, and if patient is under the anesthesia, TE can be used, which for the complication which is beyond the fluoroscope, like portion of the wall is how much it is inside, or how much it is in the alveoli, or it is outside the alveoli. But you can say wall position, exact wall position, and the procedure related complication, if there, you can identify easily. If tamponade is there, you can identify easily in the T. So for the T in GA, this is a surplus point as compared to the local anesthesia with conscious sedation. So in GA, anesthetics choice of the induction is very important. In pre-op sedation, we will give either midas. Some we also use the ketamine. 0.5 midas, 0.5 mg per kg midas can be used. 1 mg or 2 mg ketamine can be used per kg, can be used for the patient. Fentanyl approximate 5 mics per kg, and intermediate 0.2 mg for 2 mg per kg used for the induction of the anesthesia. And then we maintain on the water anesthesia or the TIVA, and or we use muscle relaxation to maintain the immobility of the patient during the aortic wall implantation, or you can say TAVI. This is that with T, if we place the T in during the general anesthesia, we see there is a paravalvular leak after the aortic wall implantation. So this type of complication is very early diagnosed in the general anesthesia of the TE place but in the local anesthesia, sometimes we miss the this diagnosis on local anesthesia. Second is pacing. Pacing is very important. It is under the anesthetist control, because we have to put the PL, the sheath in the IJV, and we put the pacing wire that is at the RV apex and maintain the rhythm. We just to maintain because it is very important when the balloon inflation or the balloon implantation is going on, we have to run a rapid pacing, approximately 180 to 200 beats per minute, which causes there is a very less ejection from the LV to the aorta, and just gives the complete immobility of that aortic part, and where the balloon implantation is going on. Side effect is very catastrophic. You can see just in this video. See, there is a pacing lead which is at the RV apex, and after the balloon inflation, or balloon is not deflated, the pacing lead will detach from the LV apex and start the contraction. And if then later it will deflate the balloon, and when the aortic wall will moves in the aortic side, move from the proximal side. That complication can occur if the pacing is continued, there is ejection continues from the LV at the time of the aortic wall implantation, or you can say balloon inflation. So, and in local anesthesia with the constant sedation, in which the all invasive lines are placed under the local anesthesia. For face mask, you can say you use partial rebreathing mask with capnography. By the groin is infiltrated with the local anesthesia, you can also give a nerve block over the or invasive lines. Sedation midas, propofol and ketamine can be used, and watch for the hemodynamics. Propofol ketamine can be used. We can also use the session with the TIVA. We can also use ketamine, ketofol. We in our should be used ketofol. Mostly it is good for the hemodynamics as our experience. Now there is a debate which is more better, general anesthesia versus the local anesthesia with conscious sedation. But we can say when we started the partner 1A, partner 1B trial, when they are taking the high risk surgical patient, at that time general anesthesia is very good for that patient. But because of the surgical improvement, because of the surgical instrument improved, medical teams have much experience about the Tavi, the local anesthesia with conscious sedation is increasing and become popular for the Tavi surgery. So now in general anesthesia we know that TE can be performed in the real time and allowing for the accurate assessment of the valve condition as well as early detection of the complications such as aortic valve dissection, thrombosis and the valve embolism. Moreover, general anesthesia prevents the patient movement so that the procedure will go very smoothly. Implantation of the balloon or inflation is done very smoothly. General anesthesia also allows the rapid conversion of the TAVI into the surgical AVR. You can just suddenly there is an intractable arrhythmia, or you can say there is a tamponade will occur. The surgical team take the handover of the patient and do surgically what they want to do, either replacement or you can say the complication they will manage surgically. G is also associated with the high incidence of the peri-op mortality and delirium due to the excessive depth of anesthesia. This is the side effect of the anesthesia. That is why the procedure time is high in the anesthesia compared to the local anesthesia shown in the various studies. We will discuss about that studies. In local anesthesia, the intraoperatively hemodynamics are maintained. There is a there is a less use of positive pressure ventilation, and it also reduces the length of the hospital stay while shortening the surgery time and the acceleration of the patient recovery. So it is a cost effective and safe also. But look, see if any complication happens in this procedure or if the high risk of the patient, we have to go with the general anesthesia. So this decision, either patient go for the GA or the LA, is dependent upon the her team, cardiac anesthesia, patient condition. Intraoperatively, if there is a complication happen, we can convert from local to general anesthesia. So this is a study showing the local anesthesia or general anesthesia which is more better. This study is done in completed in 2023 January, which data shows that local anesthesia strategy was associated with the significant reduction in the length of stay, operative time, fluoroscopy time, and the cardiovascular drugs used during the TAVI. And now we will see there is a 13 study reported, approximate 4,800 patients done in covered in that study, which shows local anesthesia with concentration is significantly have shorter hospital stay compared with general anesthesia. This is the studies from 2016 to 2017, and this is the forest plot chart in this meta-analysis, which shows that this line actually is the confidence interval, and the square point green color which shows the sample size of the population, and this shows the which study is which is more favorable. So this study is touching the line or zero line is not favor the studies, but these are the studies which shows the local anesthesia with concentration is important and favor for the TAVI. Similarly, in 10 studies, 8,000 patients, approx 8,000 patients covered, which shows local anesthesia with concentration is favor as compared to general anesthesia in respect of longer procedure time in general anesthesia. So local anesthesia with concentration have the lower procedure time. So it is cost safety also. You can say patient maybe die used in less procedure time is less, die used less, or in both GA and LA, the 30-day mortality is data after 30-day mortality is discussed. We see there is no remarkable difference regarding the 30-day mortality in this study. They shows there is a 6.33% in the local anesthesia with concentration and in 5.72 in the general anesthesia group as compared to local anesthesia. Means you can say slight mortality in local anesthesia group is higher, 30-day mortality is 6.33 as compared to the 5.72 in the GA group, but it is not statistically significant. This chart shows the 30-day mortality chart in which they slightly just you can say favor the GA, but it is not showing it. There is no study which shows GA is much good, but slight difference, but not statistically difference significant in the 30 days mortality. In AKI, there is 16 studies done and which shows in local anesthesia group incidence was 143 out of you can say 5.4%, and in GA group it is approximately 4%. That is, there were a significant difference regarding the incidence of the AKI between these groups. This means the GA group have the lowest AKI as compared to the LA group in this study, but this is done. You know, if any complication happens during the Tavi procedure, we have go from LA to GA procedure, and what complication can happen occur at the time of the Tavi? These are the cardiac arrest, tamponade, hemodynamic compromise, stroke, persistent ventricular fibrillation, can occur myocardial infarction, respiratory complication, vascular access complication, procedural complication, T-related trauma, restlessness, non-compliance of the patient. So these are the percentage which shows in these complications can occur when the patient is going into the Tavi under local anesthesia with the conscious sedation. So before the hemodynamic compromise, the patient can be electively converted into the general anesthesia, and surgeon team will take over the patient for the maintain the hemodynamics. Now, currently there is a debate between this which is more better, local anesthesia is more better than anesthesia is more better for the Tavi patient. So there is no evidence exists to suggest the anesthesia strategy with anesthesia strategy is superior during the Tavi. Based on the result of this study, LA-based conscious sedation could improve productivity by reducing the procedure time, fluoroscopy time, and the hospital stay with lower rate of cardiovascular drug usage and risk of major bleeding, but may causes the renal injury. Both local anesthesia with concentration and the GA can be used as an anesthetic strategy, but this is decided completely by the patient condition, anatomy of the valvular and the vascular access, and surgeon and anesthesiologist will decide which this patient is go for the GA or go for the local anesthesia. It is completely dependent upon the as a teamwork. When this type procedure is going on, everyone coordinate with each other and decision taken by the combined decision before any hemodynamic complication will happen. So GA will be more convenient, safer, and surgeon friendly when the fusion imaging with the transesophageal echo and the fluoroscopy become the standard. But severity of the patient condition, their expectation, and the clinical experience of the surgical team and the cardiologist is also important to decide which strategy is more better, local anesthesia with conscious sedation or the general anesthesia. That's all about the anesthetic concern in the Tavi. Still, we say local anesthesia with conscious sedation is more important, and we have to go with the patient condition and also coordinate with all the members and decide local anesthesia with conscious sedation. And if any complication happens or we think this patient is going to complicate, we just convert into the general anesthesia and continue the procedure. Thank you so much.